one Mrs. R.D. Rita Dotto, multigravida. That means having issues in her house. Admitted with labor pain. With the diagnosis of breech presentation, she and her husband is very much anxious because they do not know what is breech presentation, but they heard that this is an abnormal presentation. There is some perinatal mortality and morbidity and maternal complications also. Delivery is difficult, so they are very much anxious. You have to know about breech presentation and its antenatal diagnosis, investigations and management procedure of delivery and what complications may arise. Everything to be discussed with the patient. So we are going to start the abnormal labor. Labor is considered abnormal when it is prolonged or does not progress as expected and labor curve falls outside the normal. Hello. What are the causes of abnormal labor? The slide is very much congested. Causes of abnormal labor: abnormalities in passage, that is bony passage, that is pelvis, contracted pelvis, pelvic configuration like android pelvis, flat pelvis, platyploid pelvis, etc., etc., abnormal pelvis. Soft tissues, non-compliant cervix, that is cervical dystocia. Cervical dystocia. Cervix is not properly dilated. Congenital abnormalities of the uterus, cervix and vagina. Presence of myoma in lower uterine segment and ovarian tumors. These are abnormalities in passage. Abnormalities in power. Abnormal uterine action, that is hypertonic or hypotonic uterine contraction or irregular uterine contraction. Hypotonic uterine contraction, hypertonic uterine action and precipitate labor. Abnormalities in passenger, that is large size, abnormal presentation like face, brow, breech, shoulder, compound presentation, abnormal position, occipito-posterior position and asynclitism and fetal abnormalities like hydrocephalus, anencephaly and fetal abnormal meningocele, meningomyelocele, etc. That is congenital abnormalities. These all are causes of abnormal labor. Today we will discuss about abnormal presentation, that is breech presentation. What is breech presentation? When the podalic pole, that is buttock and legs, podalic pole or the buttocks present with legs. Legs may be extended or flexed. It is termed breech presentation. Lie is longitudinal. Lie is longitudinal, but podalic pole presents in the pelvic cavity. Buttocks, legs may be extended, flexed, etc. What is the incidence? Incidence of breech is 3 to 4% at turn, but it is more in 32 weeks, about 7%. About 7%. Although it is 7% at 32 weeks, most fetuses that present as breech before turn spontaneously to cephalic. So incidence decreases as the gestational age. What are the etiologies of breech presentation? Most common etiology is prematurity. What we are seeing that at 32 weeks it is 7%. So prematurity is the main cause of breech presentation. If the liquor volume is more, that is polyhydramnion, that is a cause of breech presentation. Multigravida, uterine tone is less, so there will be possibility of breech presentation. And multiple fetal pregnancy. If the placenta is situated in the lower segment, that is the placenta previa, that takes the lower segment, occupy the lower segment, so head cannot come in lower position. That may be a cause of breech presentation. If placenta is cornuo-fundal insertion, the position of placenta, কর্ণ এবং ফান্ডাল, সেই দিকে যদি প্লাসেন্টা থাকে তাহলে that causes breech presentation. That is placenta previa, corno-fundal placenta. If there is any uterine abnormalities like septate uterus, bicornuate uterus, or unicornuate uterus, that may cause breech presentation. If the myoma, that is fibroid, is in the lower uterine segment, so there is less space to accommodate the head, in that case, breech presentation may occur. Fetal anomalies, neural tube defect, that is hydrocephalus, matha boro, so it will be accommodated upwards in the fundus. Hydrocephalus, anencephaly, fetal neuromuscular disorder, myotonic dystrophy. Due to myotonic dystrophy and trisomy 13, 18, 21, all these can cause breech presentation, but most common cause is prematurity, polyhydramnions, multigravida, multiple pregnancy, etc. What are the classification of breech presentation? Classification: 3 types of breech presentation, that is frank breech, complete breech, that is flex breech, or incomplete breech. Frank breech, that is extended. If the fetus এখানে কি হচ্ছে, flexion at hip, but extension in knees. At this condition, if it is present, that is called frank breech or extended breech. Frank breech or extended breech, that is extension in the hip joint and a flexion in the hip joint and extension in the knee joint. This is frank breech. Frank breech is more common in primigravida. More common. Almost in breech presentation, almost 50 to 60% are frank breech. Frank breech. Complete breech, that is flex breech. All are flexed. Knees are flexed. Knees are flexed. Knees are flexed, and with this, it presents in the lower segment. In the lower segment, তাহলে আমাদের যে এটা পাওয়া যাবে পোলারিটিটা বাটক আর তার সাথে legs. This is complete breech. There is flexion at the hip and flexion in the knee. This is complete breech. Or incomplete breech, incomplete breech, there will be extension. Extension in the hip joint, but knees may be flexed or it may be extended. It may be one knee is flexed and one knee is extended, and this foot comes out, and if this condition called footling presentation. In this condition, it is footling presentation. Footling presentation. If both foot are there, that is also a footling presentation. Okay, that is incomplete breech. Complete breech is less. It is usually occurs in multigravida. It is up to 10%. And incomplete breech, 15 to 16% is incomplete breech. This is frank breech. This is frank breech. This is complete breech. This is a footling asche, pa beriye asche. This is the incomplete breech. Okay. What are the complications in breech presentation? Fetal complication and maternal complication. Fetal complication. Inherent problems in the fetus. That is, number one is prematurity. Due to prematurity, there may be during delivery asphyxia and lung maturation is not complete. So many complications of prematurity will occur in case of prematurity. Congenital anomalies. Congenital anomalies we have discussed about hydrocephalus, Santiniketan, etc., etc. Chromosomal anomalies, neuromuscular disorder. These are all inherent problem in the fetus. A complication due to breech presentation during delivery, cord accident. If there is frank breech, it fits in the pelvis well. So there is less chance of cord prolapse. But in case of complete breech and incomplete breech, that is Footling presentation, etc., there is every chance of cord prolapse, cord entanglement that may occur in that position. And during delivery, there may be birth asphyxia, entrapment of aftercoming head. This is the difficult portion. During breech delivery, buttock is delivered, shoulder is delivered, and arrest in the head. That is entrapment of aftercoming head. Aftercoming head আটকে গেল। এটাই হচ্ছে ব্রিচ প্রেজেন্টেশনে মোস্ট dreaded complication. And birth trauma. These are all fetal complication. What are the birth trauma can happen? that is birth injuries in breech delivery. In head, there may be tentorial tears. Why? Why tentorial tears? Head during cephalic, that takes time for compression. But in case of breech presentation, there is quick compression and quick relaxation after delivery. For that, there may be tentorial tears in the brain. Intracranial hemorrhage may occur during delivery. If we pull too much, there may be injury to the brachial plexus. So, Arb's palsy and policeman so that may occur during delivery. There may be spinal cord injuries also. Separation of epiphysis of femur and humerus. And also during delivery, if during manipulation, there may be fracture in the femur, fracture in humerus also can occur. So there may be fracture of femur, fracture of humerus, injury to the genitalia, scrotum, injury, there may be injury to the genitalia, and during manipulation of breech delivery, there may be injury to the abdominal viscera. There may be injury. What are the maternal complications can occur? Maternal complication due to tear, perineal tear, vaginal tear, cervical tear, cervical laceration can occur. This is the maternal complication. Again, breech can be normal breech or abnormal breech. What is normal breech? What is abnormal breech? Abnormal breech, that is, if it is associated with other maternal complications like diabetes, like preeclampsia, like post-cesarean pregnancy, that is abnormal breech. Normal breech, usually no other maternal complication, that is normal breech. Mechanism of labor. Mechanism of labor is তিনটে: breech, shoulder and aftercoming head. Breech, shoulder, aftercoming head. We know the normal delivery, that is cardinal movements of, in case of cephalic presentation, cardinal movements of head, we know all this. What are they? Now, first is engagement. Here, denominator, what is the denominator? That is the sacrum. Sacrum is denominator. And by trochanteric diameter, that is 9.5 centimeter, comes into the labor process. That is by trochanteric 9.5 centimeter. In case of, suppose in case of frank breech, presentation denominator is sacrum, so it can be right sacro-anterior, right sacro-anterior, left sacro-anterior, right sacro-posterior, left sacro-posterior. This may be 4 position. Most common is right sacro-anterior. It engages in the right oblique diameter, right oblique diameter, in the inlet, right oblique diameter. Then first is engagement. Then descent. Descent with impaction. Descent with impaction. The legs will be impacted with the body when the fetus descends. So descent with impaction. Then at the level of ischial spine, there will be anterior rotation. 1/8 of the circle anterior rotation. And anterior buttock will hinges under the symphysis pubis. And posterior buttock will slips over the perineum due to lateral flexion. Lateral flexion. This portion hinges under the symphysis pubis and breech will be, posterior buttock will be delivered by way of lateral flexion. Okay, lateral flexion. Then restitution like that. Then comes the shoulder. In shoulder, there is bisacromial diameter. It will engage in the same oblique diameter, that is right oblique diameter. Descent, then anterior rotation. Anterior shoulder hinges under the symphysis pubis. By lateral flexion, posterior shoulder is delivered first, then anterior shoulder will be delivered. And then comes head. Head may be delivered spontaneously or by assisted breech delivery or by manipulation or by forceps application after coming head. Here is denominator is sacrum, engaging diameter is bitrochanteric, that is 9.5 centimeter. Engaging diameter bitrochanteric 9.5 centimeter. A position, what are the position? Already discussed, left sacro-anterior LSA, right sacro-anterior RSA, left sacro-posterior, right sacro-posterior. Delivery of breech, cardinal movement are as follows: engagement, descent with impact, compaction, internal rotation of anterior buttock, delivery lateroflexion, by lateroflexion. How will you diagnose breech? By abdominal examination. In fundal grip, what will you get? Now, hard globular ballotable head in fundal grip. Umbilical grip, back to one side, limbs on the other side. First pelvic grip, there will be firm, broad, irregular breech. It will not be hard like head and not ballotable. First pelvic grip, firm, broad, irregular breech are not ballotable. But in fundal grip, that is ballotable. In vaginal examination, if there is dilatation of cervix, we can feel the sacrum and ischial tuberosities. Or foot or knee we can feel. And in case of frank breech or complete breech, the anus may be felt. In examining finger may be entered into the anus, and after withdrawing the finger, what will you see? The meconium. But if it goes within the face, that will not be smeared with meconium. External genitalia can be seen or felt by abdominal examination and PB examination. Information obtainable from ultrasonography. By doing ultrasonography, we can diagnose breech presentation, type of breech that can be diagnosed, fetal weight. If the fetal weight is more than 3.5 kg, we will not try for breech vaginal delivery. We will go for section. So, fetal weight can help to assess, to take the decision which method we will take for delivery. And along with that, like location of placenta, volume of liquor, amniotic liquor, that is amniotic fluid, if it is less, so then in that case we will not try for vaginal delivery, we will go for cesarean section. Confirmation of gestational age, flexion, extension of head. If the head is extended, gaze starting, উপরের দিকে তাকিয়ে আছে, extended, that is not a fit for vaginal delivery. You have to do cesarean section. Fetal anomalies, is there any fetal anomalies? And uterine anomalies also can be diagnosed by ultrasonography. All this information we can get from ultrasonography. Management, antenatal management. Antenatal management is external cephalic version. In external cephalic version, if it is complete breech and the liquor volume is good and the patient is multigravida, external cephalic version is easier. In that case, you have to dislodge the breech from the pelvis. So, by this way, we will dislodge the buttock from the pelvis. Okay. Then we will follow this way. Arrow shows buttock is held with the right hand and head is held with the left hand. And you have to forward movement so that head can come to pelvis, forward movement. If it is RSA, you have to hold the buttock and with the left hand head, you have to give pressure towards forward movement so that it can reach the pelvis. By turning this, you will do it in transverse position. Then change your hand. In that case, you will have to put your left hand over the head, fix the head and change the hand. Then it will go down this. This way we will do the external cephalic version. Okay. Before doing external cephalic version, we have to see whether there is any contraindication of external cephalic version. External cephalic version, short node may come. It may, if it is a post-cesarean pregnancy case or repeat CS case or oligohydramnias or any congenital abnormality in the uterus or placenta previa, all are these contraindication or any abnormality in the congenital abnormality in the fetus, you have to avoid external cephalic version. These are the contraindication. External cephalic version will be success in case of good amount of liquor amni and the average size baby. Time for external cephalic version. When we will do external cephalic version? If I do at 32 weeks, it will revert back. So time for external cephalic version is 36 weeks in case of primigravida. After that, usually position does not change. So 36 weeks is the time for external cephalic version, and in case of multigravida, 37 weeks is the time for external cephalic version, ECV. After, will you do a external cephalic version under general anesthesia? No. If you give general anesthesia, you can give more pressure, but slight sedation you can give. but no general anesthesia. And before doing external cephalic version, you have to do the fetal topography, that is normal, fetus is normal. After doing external cephalic version, you have to do fetal topography to prove the fetus is well, and also look for the any vaginal bleeding is there or not. After successful external cephalic version, vaginal delivery may be allowed, because in case of vertex presentation, normal delivery, complications of fetus and mother is less. But today it is controversial whether I will do ACV or not. Today this is controversial. Today we are doing in all cases of breech presentation cesarean section. Nobody cannot take any risk of external cephalic version, but it can be done. Mode of delivery in turn breech, elective cesarean section, vaginal breech delivery. Indication for elective cesarean section in breech presentation. Estimated fetal weight, if it is more than 3.5, that is big baby, vaginal breech delivery will not be allowed. Incomplete, Footling breech, not allowed. Hyperextended fetal head, then stargazing. Complicated breech. Complicated breech means breech presentation along with maternal complication like PIH, diabetes, post-cesarean pregnancy, IUGR, etc. Placenta previa will not allow vaginal delivery. And contracted pelvis. Contracted pelvis, you have to do cesarean section also. Criteria for patient selection for vaginal breech delivery. Complete breech, you can allow estimated fetal weight from 2 kg to 3.5 kg, that is average size baby, and flexed head is flexed, uncomplicated breech. You can allow, and pelvis is adequate, you can allow the breech delivery. Vaginal breech delivery, it can be assisted breech delivery, total breech extraction from beginning to end. You do the breech extraction, that is total breech extraction, or spontaneous breech delivery. Multigravida patient came, lie down over the table and deliver the baby in breech presentation spontaneously. No help required. That is spontaneous breech delivery. Come assisted breech delivery. General guidelines for interpartum management. Fluid, etc., oxytocin, ityadi. Now come the assisted breech delivery. Assisted breech delivery is one where the fetus is delivered spontaneously up to the umbilicus. Spontaneously, fetus is delivered up to the umbilicus. The umbilicus is up to the umbilicus is delivered. You have to do assisted breech delivery up to the umbilicus, and the rest of the body is delivered by various maneuvers. The following personnel and equipment should be available. Skilled obstetrician, number 1. Able assistant. Gamma assistant is required to give suprapubic pressure to maintain the flexion of the head. Neonatologist must be there. Facilities for lithotomy position and forceps for aftercoming head. If required, forceps may be given. So, baby is spontaneously delivered up to the umbilicus. After that, you examine the baby and palpate the umbilical cord. Pulsation is good. Then pull down slight portion of the umbilicus so that abnormal tension or compression cannot occur. For that, you have to pull some portion of umbilical cord and keep it in the bay of sacrum, and the body and leg will be covered by warm towel. Buttock is, we are seeing the buttock up to umbilicus is delivered. And you have to grip the pelvis, femoro-pelvic grip. For that, index finger will be over this and the thumb will be over the sacrum and parallel to the spinal. It is wrapped with the one towel. Then it is allowed to hang with its own weight. নিজের ওয়েটে আমি ঝুলতে দেবো। Then comes the shoulder. If it is seen any portion of the angle of the scapula, wait for to see the angle of the scapula, and along with that the shoulder or any portion of the hand can be seen, that can be released over the face, gently. Then if another shoulder is seen, that will be delivered easily, and then allowed the fetus to hang by its own weight. Patient is in the lithotomy position. In breech delivery, don't make hurry. Have your patience, and your assistant will give the suprapubic pressure to maintain the head flexion. When the hairline is visible, then you will have to deliver the head. Before that, don't be hurry. Time for safe vaginal delivery from seeing the hairline to delivery, 2 to 3 minutes is safe. If it is more than 5 minutes, there is chance of fetal asphyxia. So, baby is allowed to hang. Delivery of the aftercoming head by 2 methods can be delivered. Number 1 is Burn-Marshall technique. Number 2 is Mauriceau-Smellie-Veit technique. What is Burn-Marshall technique? Now, baby is hanging with its own weight and the hairline is visible. You wrap the baby with the one towel and grip the leg in this way. This finger is there and ring finger is there. Index and middle finger in between the leg. Then pull slightly and form an arc and towards the mother's abdomen. The baby will be delivered spontaneously. At that time, the assistant will give suprapubic pressure to maintain the flexion of the head. This is the Barn-Marshall technique. What is Mauriceau-Smellie-Veit technique? That is jaw flexion, shoulder traction. Jaw flexion, shoulder traction. Jaw flexion. You place the fetus over the left hand. Over the left hand. This is the maxilla. Put your hand, finger over there. Okay? And in left hand. Left hand. By right hand, you will place your index finger in the one shoulder, middle finger over there to maintain flexion, ring finger is there. So slow, there is jaw flexion. এই ফ্লেক্স করছি and shoulder কি করছি ট্রাকশন দিচ্ছি ফার্স্ট some downward traction and then maintaining an arc you will extend by way of this raise the fetal head over the mother's abdomen. This is the Mauriceau-Smellie-Veit by jaw flexion, shoulder traction. Okay. And then is the এটা হলো তোমার বার্ন-মার্শাল মেথড আর এইটা হচ্ছে জ ফ্লেকশন আর শোল্ডার ট্রাকশন মেথড দ্যাট ইজ Mauriceau-Smellie-Veit মেথড আর হচ্ছে আফটারকামিং হেড forceps application. If you need forceps application, ideal forceps is Piper's forceps. It is low forceps. It is usually not used in our country, but ideal for breech extraction, that is aftercoming head delivery by Piper's forceps, or you can use the low forceps like Das's forceps, like forceps. For that reason, application of the forceps will be from below. In case of vertex presentation, from above, আমরা দিচ্ছি. But in case of breech presentation, you will have to apply the forceps from below. For that, with one cloth, you will place the fetus একদম তোমার বলির পাঁঠার মতো তোমাকে নিতে হবে একদম ওপরে বলির পাঁঠার মতো চাদর জড়িয়ে এই ওপরে দিয়ে নিচ দিয়ে তুমি দুটো ব্লেড দিয়ে তারপরে তুমি ডেলিভারি করবে দিস ইজ দ্য forceps delivery of aftercoming head. Difficulties in assisted breech delivery: extended legs, extended arms. In case of extended arms, that is গৌরাঙ্গ, যদি গৌরাঙ্গ থাকে তাহলে কি করে বের করব এক্সটেন্ডেড আর্মস তখন Lovset's maneuver. This is Lovset's maneuver. In Lovset's maneuver, এইটা শুধু শুনে যাও Lovset's maneuverটা একটা হলো বার্ন-মার্শাল, একটা হলো Mauriceau-Smellie-Veit, আর হচ্ছে Lovset's maneuver. Lovset's maneuver কিসের জন্য না এক্সটেন্ডেড হেড, এটা দিয়ে এক্সটেন্ডেড হেড, এই extended hand, এই extended hand রয়েছে আমরা কি করছি না lower end of scapula is visible and then examine and then you found that the leg, hand are extended. In that case, keeping the back of the baby upwards, grip the femoral grip, and then you rotate it. You rotate it in this way. This pelvic outlet, this is less, so this is open. Anterior shoulder automatically come out. Just you release this, and then in opposite direction you will rotate this. In opposite direction you will rotate this way. This will come out. This is called Lovset's maneuver. By Lovset's maneuver, you can release the extended arms. This is Lovset's maneuver. Or the bringing down the posterior arm. হাত ঢুকিয়ে বের করতে পারো under anesthesia. Entrapment of aftercoming head. যদি incomplete dilatation of cervix হয়, সেখানে by giving incision over the cervix you can deliver the head. Posterior rotation of head, rotate trunk and head anteriorly, a Prague maneuver. Total breech extraction, that is entire delivery by obstetrician, from buttock, from foot up to the head. It should be done under anesthesia. Anesthesia required. Indication: second twin. First twin is delivered. In second twin, after internal podalic version. In case of internal podalic version, in twin delivery, first delivery baby is delivered. Vertex presentation delivered. Second baby is breech. In that case, you can do internal podalic version. আমরা কি করেছি? Antenatale external cephalic version. But in case of second twin, if it is breech, you have to do internal podalic version. Under anesthesia, you have to catch the legs by introducing your hand. You catch hold the legs and দড়ি ধরে মারো টান, সোজা এই টানলে পরপর বেরিয়ে আসছে এবং তুমি অ্যাসিস্টেড ব্রিচ ডেলিভারি, লবসেট ম্যানুভার ইত্যাদি, আফটারকামিং এড এসব করতে থাকলে, দ্যাট ইজ হচ্ছে টোটাল ব্রিচ এক্সট্রাকশন.